The broadcast is now starting. All attendees are in listen-only mode.
Hello, welcome to our webinar on hepatitis B and C in the African immigrant community. This is Margaret Corto from the Office of Minority Health Resource Center, and I'm very happy to introduce my colleague and friend, Dr. Koku. He's an associate professor with the Department of Sociology at Drexel University in Philadelphia. His current research examines socio-demographic determinants of HIV risk in Africans and its diaspora, the lived experiences of persons living with HIV in Africa and the U.S., as well as professional and informal networks of academic researchers and policymakers. His publications have appeared in a number of peer-reviewed journals, including American Behavioral Scientist, the Global South, Journal of Community Health, Sexual Health, Journal of Online Learning and Teaching, and Asian Ethnicity. Aside his scholarly pursuits, Dr. Koku is actively engaged in applied policy related to initiatives. He is currently working with the Office of Minority Health Resource Center on addressing health-related disparities in African immigrant and refugee communities in the U.S. In particular, he co-developed the office's anti-stigma curriculum for use in African immigrant communities. He also co-authored the office's policy brief on HIV data disaggregation, which he later edited and just published in a Journal of Healthcare for the Poor and Underserved. Dr. Koku is also a consultant on most of the culturally appropriate educational materials and trainings from the Office of Minority Health Resource Center. He is also the lead National Planning Committee member on the upcoming United States Conference on African Immigrant and Refugee Health, which is taking place in New York, September 15th to the 18th. Thank you, Dr. Koku, for being here and helping us educate our community members about hepatitis B and those who work with our community.
Yeah, thank you very much, Margaret, and thank you for all the participants for taking the time off to come to this webinar, and thanks to the Office of Minority Health Resource Center for putting this together and for all the resources they've actually provided in tendering to the healthcare needs of minority populations in the U.S. So the webinar today will discuss mainly Hep B, hepatitis B among African immigrant populations, and some ideas about issues that affect the knowledge, attitudes, and behavior towards Hep B and its prevention. So I've organized the presentation into 4 main units. The first part might seem like preaching to the choir, so I'll be very brief in it. I'll make some introductory comments on what Hep B is and contrast it slightly with Hep C. And in the second part, I'll focus mainly on Hep B and C in the African immigrant communities. I know that the focus of the seminar is actually on Hep B, but because of sometimes the blurred understanding between both Hep B and C, I'll make some brief comments on Hep C as well. In Units 3 and 4, I will discuss some of the barriers that people within African immigrant communities experience in Hep B prevention and treatment, and come up with some suggestions about how to address those barriers. And then in the final section, I'll my attention on how we can best engage African immigrant communities in Hep B treatment. But before I start, I would want to give some few comments on the African migrant populations in the U.S., which we know have been increasing, particularly since the late 80s. Currently, African immigrant populations comprise a small, but definitely an increasing share of the U.S. populations. What is unique about it is the fact that their demography, they are scattered very much throughout the U.S. The largest concentrations are mainly in the big cities, particularly in the Northeast, though parts of the Northwest also are receiving refugee populations in particular. Most Africans, the current ones, actually come from countries such as Nigeria, the big populations from Nigeria, Egypt, Ethiopia, Ghana, and Kenya. Many African immigrants who come in are evenly split. Most of them are male, increasingly female, fairly well educated. One of the interesting things about the population, however, is the low rates of naturalization, which are often emphasized as a lot of impact on health behaviors. This implies that they tend not to see themselves as permanent residents in the US, but rather as people who are migrants who are likely to go back and forth home. And therefore, this constant process of communication, this constant process of engaging with their communities back home has a lot of influence on the way they experience US healthcare system, the way they interpret it, and the way they revive their culture. A key characteristics which I'll get together is a multiplicity of languages that are prevalent within the population, so that when you talk of an African immigrant population, you are not just talking about one monolithic entity, but you are talking of a population that has a variety of cultures, variety of language, variety of behaviors, varieties of expectations and interpretation of health behaviors, and health outcomes. And therefore, trying to approach the population really requires some level of understanding and some level of engagement with this diversity that it comes with. So I'll set aside a brief socio-demographics aside and then talk a little bit about Hep B and C. As I said, I'll be very brief. So essentially, all this viral hepatitis is a disease that affects the liver, which means that the person who has a hepatitis has a liver that cannot function very well. There are three most common types of hepatitis, A, B, and C, and these are actually caused by viruses. So what happens is that all three of them can be acute, which means they can start very quickly and be over very quickly. But attention, Hep B and C pay a lot of attract a lot of attention because only those two can be chronic. And the person can get infected and deal with these effects over a very long period of time. Hep B is caused by what is called the Hep B virus, or commonly called HBV. And in some sense, like HIV, it is spread through infected blood and other bodily fluids such as semen and such as vaginal secretions. A person therefore can get infected if they have a unprotected sexual intercourse. If a person who is infected tear needles or have an accidental needle stick injury from a needle that has come into contact with an infected blood. A child also can get infected during birth if their mother is infected with the Hep B virus. However, newborns can be quickly vaccinated to avoid getting infected. Almost all infants who get infected end up having chronic Hep B. So how can a person know that they have a Hep B? The simplest thing is by having a blood test. The blood test can also help determine whether one has an acute or one has a chronic infection. And in some rare cases, doctors may actually go further and remove a small sample of liver for more extended testing to see the extent to which the liver has been damaged. And as I said, chronic Hep B, people may become infected and they may not actually be very aware about the state of the infection, but they can still pass the virus. And if the symptoms occur, it may actually take up to 75 days after a person contracts the virus. And these symptoms may include fever, joint pain, nausea, vomiting, and so on and so forth. But again, not everyone who is infected with Hep B will have any or all of the symptoms. So the key issue is if one knows that one has been exposed to Hep B by sharing needles or through contact with someone who might be infected, the person has to contact their doctor immediately, because there are specific preventive treatments that can be taken within 24 hours of exposure to reduce the risk of infection. So who is at risk for Hep B? Anyone who is not vaccinated can get infected. So anyone who is not vaccinated can get infected. But high-risk groups include people who travel to or live in areas that have high rates of Hep B. Men who have sex with men, injection or non-injection drug users, healthcare workers, and so on and so forth, people who have multiple sex partners, people with chronic liver disease. An interesting thing about Hep V is that it can survive outside the body for at least a week, which makes it very virulent. And during this time, the virus can still cause infection if it enters the body. So unlike viruses who don't have long longevity outside the body, this can survive at least for a week and still remain very active. So as I indicated earlier, vaccination is the recommendation that the CDC recommends against Hep B among children and high-risk groups. When it's acute, the virus can heal on its own through good rest, healthy diet, and so on and so forth. However, a chronic Hep B needs much more attention, and it's only a physician who can give the needed monitoring that can lead to the risk, that can reduce the risk of liver disease. There is no cure for chronic Hep B, and it is because of this that testing is very important, and it's only a blood test can help the doctors determine whether Hep B is acute or chronic, and if it's chronic, then treatment needs to be started. As I said earlier, I'll make a few comments about Hep C. Just like Hep B, it is also spread through contact with infected blood. And people can get infected through sharing needles, sexual contact, or contact with other forms of exposure through blood. Unlike Hep A or Hep B, most people are likely to die from Hep C, mainly because of the possibility that people can actually have what is called a cirrhosis of the liver, or liver failure, liver cancer. So again, just like Hep B, blood test is the definitive way to get tested for Hep C. Hep C again is a silent killer because most people do not experience any symptoms, yet they can transmit it. And therefore, it becomes very important for people to keep up with blood tests to be able to rule out Hep C infection. The same groups that are at risk for Hep B are also equally at risk for Hep C. However, there are additional groups, people who have been in prison, people who are living with HIV, and particularly baby boomers, people who are born between 1945 and 65. And therefore, there is need for increased attention to this particular population. Hep B and Hep C usually manifest through co-infection with HIV. And therefore, all those who are infected with HIV needs careful attention as to their Hep B and C status to be sure that co-infection doesn't exist, because if it does exist, it really triples and complicates the manifestations and the effects of each of these diseases. Okay. I'll shift my attention now to Hep B and C in African immigrant populations. First, I'll look broadly within the black populations, what is the rates of Hep B within these populations, and then look specifically at the subset of the black population, the manifestations of Hep B within African migrant populations. Generally, within the US, black populations are more likely to develop liver complications and die from Hep B and C than other racial groups. Several statistics exist on this, and that the number of cases of Hep B and C are highest among black populations, and number of deaths related to Hep C are actually 2 times greater for blacks than whites. So for example, the incidence rates, close to 8.4 deaths per 100,000 population versus 4 deaths per 100,000 populations for whites. So the risk is almost double. And again, almost 3% of the black population is infected by Hep C compared to about half of the white population. And similarly, and proportionately, black communities also have predominantly higher risks of HIV and Hep B and C co-infections. Within a subset of black populations, we have black migrants from Africa, or what we are called African migrants. And within the black population, rates of Hep B are highest among migrants from Africa. And if you look at the map on the right side, you'll see the various legends there. So what you realize is that migrants from continental Africa come from populations where more than 8% of the population is infected and living with Hep B. So I often say that the rate of Hep B is inversely proportional to the population of migrants from Africa in the US. So although African immigrants make up less than 1% of the total US population, they account for over 11% of the cases in the US. And similar rates exist among African immigrants living in the US with respect to Hep C as well. High rates of infection with Hep B and C has a lot of impact on productivity, on health, and so on and so forth, on unemployment, increase in poverty, and we not need to go through all of this. So how do we address the barriers to Hep B and C? There are several barriers. Lack of information is foremost, followed by lack of testing, stigma, access barriers, side effects, and other health conditions that compete with or co-contradict the existence of Hep B. So we take each of them, and for each of them, we'll try to come up with some solutions or some suggestions as to how to address them. There is information about Hep B and C, but most people don't know about this. And even if they have access to them, they are not able to understand it at the level at which they are written. People need information about the risk factors. People need to know how to prevent the infections. For example, they may not know that vaccines actually exist against Hep B. Apart from the information itself, people may not know where to get treatment from, where to get tested, and where to go for. People may not know where to get treatment from, where to get tested, or the type of resources that are available to be able to protect themselves from Hep B very carefully. People may not know what the symptoms actually are also. And with respect to the African immigrant population, information in a language or at a level that they understand is equally important. So having the flyers in English is equally okay, but that caters only to the educated population. This information needs to be translated in languages that they understand, that they can absorb and apply to their lives. So how do we fix this? Resources have to be made available on the websites of health and social organizations. Some of these are available by the CDC, the fact sheets, but these can be translated into languages that the communities can absorb. Beyond providing this type of resources organizationally, this information also has to be disseminated within the community and by community members and health workers that deal with the community. So this could be done through churches, through religious leaders who can devote some sections of their meetings on Hep B. Educators can also begin having conversations in their circles about viral hepatitis. Healthcare workers can organize small meetings where they assess the community's level of knowledge about Hep B and C and use that to raise awareness. I'll get down to stigma a little bit later, but if feasible, people who have experience with Hep B could also be invited to share their personal stories and experiences to raise awareness about the condition. As the literature from HIV risk indicates, one consequence of lack of information is lack of testing. So too few people get tested. And worst of all, we don't even have the level of information that we need to be able to gauge the extent of testing within the African immigrant populations. Like HIV, testing data is not disaggregated by country of birth. So we do not know the prevalence or the rates of testing within African immigrant populations or other minority groups in the US. So the data we have are few cases anecdotal that are based on clinic to clinic and sometimes are based on small local studies. So testing is recommended for people born in regions where Hep B is endemic. So testing is important for all risk groups that I identified earlier. And because there is no vaccine against Hep C, testing is actually much more critical. One way to increase testing is information accessibility, which I talked about earlier. So we need to have information available on community websites that testing is available and that testing is very critical for prevention Hep B. Word of mouth, person-to-person conversations are really vital for spreading the information about testing resources. In addition to spreading the information about testing, we also need to have places available where people can test. Stigma is a huge issue with regard to Hep B and C because of its close association with HIV. And in African communities, the same stigma that is associated with HIV tends to be applied to Hep B because they both share the common sources of infection, that is through sex and also through needle exchange. So people might be ashamed to talk about Hep B because it is linked to sex. And as our work within the African community has shown, because HIV and sex are equally taboo subjects, there is some level of resistance that community members express about getting to know their status about HIV about Hep B, because they are afraid of the consequences of finding out if they are infected with HIV, with Hep B, because it doesn't matter, because it is associated with sex and sexual transmission. There are all the negative attitudes and constructions of HIV that are technically and then automatically applied to those who have Hep B. And in fact, in some of my earlier research, I have participants tell me that one way that people conceal their HIV is by passing it for a different disease like hepatitis B. So acknowledging knowledge or acknowledging infection with Hep B might actually be a signal to some that one is actually HIV infected. And therefore this stigma has to be addressed and broken. Educational programs is essential for destigmatization. And encouraging testing, paradoxically, is one way by which we can reduce stigma. The needle exchange for injection drug users and sex education are all ways by which we can decrease the stigma and then increase testing. Another way that we can decrease the stigma that is associated with both Hep B and also by implication with HIV is to make efforts towards acceptance and inclusion of MSM in African communities. This becomes very important because by creating this atmosphere of acceptance, by creating this atmosphere of inclusion, all the diseases that are associated with these types of lifestyles will then become much, much more acceptable and less stigmatized. And this type of acceptance would therefore then encourage people to attain better health status, stay uninfected, and seek testing if they are exposed in one way or the other. Beyond the individual level factors, knowledge, information, education, testing, and stigma, there are also structural barriers that affect Hep B prevention and treatment within African immigrant communities. One is lack of health insurance, and then of course the increasing cost of healthcare. And this becomes very important within African immigrant communities where you have higher chances of people who are undocumented and therefore people who do not have access to healthcare and health insurance. Time is a crucial variable. And because within the community, health often competes with employment, work, educational demands, efforts have to be spent on increasing knowledge about the importance of preventive care. Very often, the health behaviors that migrants exhibit in their countries of destination are related very much to the health behaviors that they have learned in their countries of origin. And therefore, in cultures where preventive health care is not necessarily the norm, either because of lack of finance, either because of inaccessibility to hospitals, or either because of lack of education, we see this type of behaviors being exhibited in their countries of destination. And therefore, it becomes important to stress to members of the community to make time to have checks done, to have testing done, and make the resources available for this to take place. Along the same lines, community members also have to be able to understand how to navigate the healthcare system within their countries of origin, in other words, of destination. In other words, they have to become culturally fluent with respect to health, so that they know how to make appointments, they know how to report on time, they know that they have to ask questions. We call all this cultural fluency or cultural competence, or whatever the term that is used for it. At the same time, however, the healthcare providers also have to be able to understand the culture or be aware of the context of their migrant patients. And some of these contexts include language barriers, educational barriers, and other broader barriers that affect their welfare. For example, legal status, unemployment, levels of education, and family constraints, and so on and so forth. With respect to the Hep B, there needs to be concrete information. Hep B vaccines require 3 doses. And people may not complete all these doses because they may not think it's very necessary. So retention in care becomes a very crucial variable that one has to pay attention to. And for healthcare clinics, this becomes a very huge demand, because how do you encourage people to return? You might be able to get them in the first instance, but encouraging retention becomes a burden. How do we incentivize it? Some literature talks about incentivization. Is it necessary at all? But these are questions that I think need discussion to be able to encourage adherence to clinical protocols. So the healthcare barriers, information again is important. Preventive care needs to be emphasized. Some concrete things we can have that we can do is have a list of clinics and testing centers that have weekend hours or evening hours, so that those who don't have time, who cannot take time off their jobs, would be able to make time to go see their doctors. Having a lot more members within the community. Invisible minorities actually become visible minorities in the healthcare field is very important. This helps foster and helps the integration of migrants into their communities. It also helps in translation of health information to migrants who may not understand. Culturally sensitive and culturally appropriate care need to be provided, and this is not only related to language, but it's also related to age as well, because within African communities and in some religions, it is considered there are age and gender barriers that must not be crossed in provision of healthcare. So when it comes to conditions that deal with sex, for example, as a participant once told me in an interview, I cannot sit down and talk about sex. I'm paraphrasing here. I cannot sit down and talk about sexual issues with my doctor, who is just like my daughter. In other words, there is an age barrier there. So one has to pay attention to these types of invisible barriers that may influence the healthcare delivery process. The same way it goes with gender as well, so that providing appropriate care goes beyond just language. Sometimes it has to do with gender, sometimes it has to do with age, which has to be taken into consideration. Peer navigators are very important, and I spoke about it earlier with respect to having members in the community spearhead the efforts towards accessibility and consumption of health information and health services. There are side effects of treatment that people are afraid of, and that affects, one, their decision to seek care, treatment, and also to adhere to treatment. And therefore, some of these have to be demystified, some of these have to be explained. The cost and effect calculation has to be, fairly explained. One has to be able to balance the long-term positive effects of treatment against the negative health complications that would result if Hep B is left untreated. Members could also be encouraged to share their fears with their doctors, ask questions, make comments, probe, and ask for different types of treatment that would limit some of the side effects that they may experience. There are other health conditions that could complicate manifestations of Hep B. So health conditions, diabetes, heart disease, HIV/AIDS, sometimes may take priority for Hep B. So for somebody who is living with high blood pressure, for somebody who is living HIV, conceptually, they may think that HIV is much more important than Hep B, and therefore they may postpone treatment for Hep B. So one has to educate the community about the importance of holistic health in the framework of the broader determinants of health, and emphasize that one condition should not be ignored because all of them are interconnected, and neglect of one may indeed worsen another condition. Support groups are very vital because of the stigma, because of the lack of information. Community health workers, in fact, can help form support groups of people who have known, who are willing, and who have experienced Hep B or C or even HIV, so that community members who are part of support groups can help disseminate the information among themselves and also disseminate it outside the support group itself. And emphasizing holistic health also means that one has to encourage healthy diet, regular exercise, taking medications as prescribed, so that the attention itself is not necessarily on Hep B per se. In fact, that becomes one of the ways to reach African immigrant populations, where you approach conditions from a holistic health perspective and use it as a standpoint to introduce attention to Hep B and so on and so forth. In other words, it becomes important to incorporate Hep B within the framework of broader health concerns that members of the community face. What I've done so far is briefly discuss what Hep B is, what the barriers are, and how we can address them. So how do we do this? How do we engage African migrant communities? Because they can't just be idle participants in this process. African immigrant communities have to be in charge of their own health and become active in Hep B prevention and treatment. Two main ways of doing this. One is to build individual and community capacity. And the second process is to bridge the gap between community and public health and social service systems. So I'll discuss the first and then the second. So how do we build individual and community capacity? The first, of course, is to break the silence in smaller circles, from our families, from our communities, from our community meetings, among friends. It becomes important to encourage the community to start talking about viral hepatitis. Information leaflets about Hep B, Hep C, and other health conditions can be disseminated by print, orally, online, or posted in mosques, other Christian gatherings, in barber shops, beauty shops, and so on and so forth, so that they are easily accessible. Like other communities, African communities are known for their social gatherings. And therefore, health promotion events can be built into these social gatherings. And these afford the community members opportunities to talk about HIV, Hep B, and C. All within a context of holistic health, about healthy diets, exercise, safe sex practices. So, in other words, what I'm saying here is that instead of going and saying that, well, I'm going to talk about Hep B and C, it is more practical to begin the discussion with a holistic health. Let's talk about diet, of course. You have a lot of people who are interested in it. Let's talk about exercise. You have. And then slowly start introduce questions or discussions about the more sensitive issues like sexual health, HIV, and Hep B. In other words, dissemination about Hep B information has to be fitted within the context of broader health issues. And as part of these community events, it becomes very important to also invite community members who have some knowledge or experience about Hep B to share these experiences, and that will help address myths misconceptions and allow people to have direct answers to some of the questions that they may have. Beyond building individual capacity, how do we bridge the gap between the community and then the health and the social systems? One, again, is knowledge. So one is to increase this knowledge and educate the community on free screening services available at most local public health departments. So these are resources that are already existing, and therefore the community members need to be encouraged to take advantage of these free services. Again, because of the likelihood that some community members may be concerned about immigration and legal status, it becomes important to emphasize that the consumption or the receipt of these services will not jeopardize anyone's immigration status in the country. If the first option, encouraging people to come to local public health departments, becomes difficult, there are other community agencies that help with insurance and other benefits and that have been engaging in the community for a very long time. Community members may be much more comfortable in dealing with local CBOs that they have grown to trust to provide services that are culturally appropriate for their needs. Community members need to be encouraged to take advantage of those services in the CBOs as well. Resources, support groups, both offline and online, medical assistance programs, patient navigators, all of those needs to be improved to allow community members to bridge the gap and increase their access to social service systems. Communication with healthcare providers is key. How do we improve it? Community members need to be encouraged to attend meetings about their health issues. Annual physicals are important. They can serve on advisory boards within their communities. Members can also clarify cultural practices that negatively and positively impact health also, and help educate their providers so that healthcare can be delivered in a culturally appropriate fashion. Navigation of the healthcare system is a crucial need, particularly for new migrants. And this affects their preventive behaviors. So how can we help them in this process? One way, of course, is to help them to talk about Hep B and C with their physicians, even if their physicians don't ask them. Community members need to be educated to ask these questions, to take the proactive step. And in fact, this becomes very important because when one comes from cultures that are fairly paternalistic, where the social divide between the doctor, the professional, and the community member is very wide, what you hear very often is that it is the doctor that talks, and the professional training of the doctors themselves, the socialization emphasizes this. And therefore, you are likely to encourage community members who see themselves not as active participants in the healthcare process, but actually patients who have to be taken care of by the doctors. Indeed, they are patients, but of course, it's important to emphasize that they have a very important role to play in their healthcare systems, and therefore, to prepare them for the meeting with their healthcare appointments, encourage them to ask questions about the side effects, alternative treatments, outcomes, and so on and so forth, so that it can help calm fears, hesitations, or apprehensions about different types of treatment strategies. Beyond advisory boards, community members can also volunteer in clinics, in screenings, and part of other social service systems to help their integration. And once fully integrated, research has shown that community members are able to take advantage of social services that the community offers. I spoke earlier about the importance of preventive care, and this cannot be overemphasized. Prevention is cure. That message has to be driven repeatedly. Cultural sensitivity or cultural fluency are fairly overused words, but essentially what it means is that outreach and enrollment strategies have to be suited to the cultural tendencies and cultural needs that are particular to a population. So within African immigrant communities, what does it mean? Focus on holistic health. Most providers working under private insurance will devote merely maybe 10-15 minutes for a meeting with their patient. Within African immigrant communities, more time is needed to bridge the cultural gap between the healthcare systems in the Western countries and what consumers have known from their countries of origin. And therefore, instead of going directly to issues about sensitive issues, it has to emerge gradually through a conversation with the patient. The focus on holistic nature of health means that healthcare issues are not usually seen in isolation. Somebody who believes that he or she is exposed to Hep B would often tend to see that Hep B within a context of other broader influences that are affecting the person. Maybe the person's family, maybe the person's legal status, it may be the person's employment pressures, and so on and so forth. And therefore, the conversation about a specific health issue has to be situated within the broader framework of the person's life experiences and life chances. Instead of framing prevention, as I've stated earlier, that prevention is cure, we also need to be able to move beyond prevention as an individual strategy and focus it more as prevention as a strategy for helping the family and community development. And therefore, what that means is that explaining to the patient that, well, the prevention is not only good for you, but also for your family, and so on and so forth. Taking values, beliefs, and language into consideration. I've discussed a few of these earlier. Values about language, values about gender, values about age, and values about the topic itself are very critical. Sex is usually seen as a private discussion between two adults, and therefore those values enter into the therapeutic framework. And of course, one has to ensure that services are provided in a fair manner without discrimination, prejudice, and so on and so forth. So in a sense, there are several issues that affect knowledge, attitudes, and behavior related to Hep B within African immigrant communities. To be able to understand this, one has to acknowledge the various socio-cultural forces that influence and that determine how people perceive the knowledge, how people receive it, and how people assess these services. it becomes also important to use what we call the patient-centered approach. And that approach involves focusing on the patient as part of a holistic sphere involving not only the disease at the center, but also surrounded by an interconnected network of family, peers, community members, and larger social services that affect their consumption of health. And importantly, realizing that this network may actually extend outside their countries of destination. In other words, through influences, communication with their countries of origin, they are able to revise, reinvigorate, reframe some of the messages that they hear within their countries of destination. And therefore, this dialogue has to continuously take place as part of the patient-centered approaches. And make resources and language available. And hopefully, it is through this multiplicity of resources and approaches that we can help increase Hep B preventive care and treatment. Thank you very much.
Dr. Koku, thank you so much. And the audience, thank you so much for staying on and listening to everything. We really appreciate it. We have time for maybe a couple of questions. So Dr. Koku, there's one question that I'm going to read out two questions because we're only 4 minutes away.
Okay.
The first one is we are seeing multiple chronic conditions or comorbidities of Black patients with diabetes, Huntington's disease, sickle cell disease, cardiovascular, obesity, fatty liver disease, HIV, along with either HCV or HPV, HBC. Early detection may be helpful in minimizing multiple chronic diseases due to health deterioration from compromised immune systems. Are you seeing the situation in the African immigrant population too?
Yes, in fact, the comorbidities is really very key, particularly with respect to HIV. Mainly with HIV and Hep B and C, mainly because of what the immigration processes, the rates of detection, right, the testing for HIV has actually gone much higher than that of Hep B. And therefore, what happens is that people live within the community with untreated Hep B for a very, very long time. Okay, so there is a very close comorbidity issues going on there. And also with respect to hepatitis, again, it's all about what? The lack of attention for preventive health, right, which needs to be emphasized over and over again. So all these things are increasing. And as I think I said earlier within the webinar, people tend to prioritize which of the health conditions I think is most visible. And unfortunately, all these conditions, none of them is really that visible until it has completely worsened and reached fatal levels. So people want to be able to see visible consequences or visible manifestations of these diseases. And very often, people never get that such a chance before it is too late. And therefore, attention needs to be paid, as I was talking about, holistic health. Attention needs to be paid not only to one health condition, but to all of them at the same time.
Okay, thank you, Dr.
Even,
yeah. Go ahead.
Yeah, and even if the patients themselves don't ask, this needs to be checked and asked of the patients, and tests provided and suggested.
Thank you, Dr. Koku. There seems to be several questions coming now. So what we're going to do is send the questions to Dr. Koku, and he will answer them via email. There's one question that just came up that I might be able to answer. It says, have there been any successful programs to model after to effectively get the word out about Hep B with this demographics? One of the things that we've been doing is going to churches, because churches are very important in the African community. So we've been going, collaborating with churches to go in there and do the testings at the church, or having the churches organize something out of the church where we can go in, like Dr. Kuku said, to do a holistic educational piece, we do different things in addition to the hepatitis B. And we're even in the process of planning to do a testing event at a concert that is going to be done by an African artist. So it seems to work better when you take it where they are instead of inviting them in to do it. Dr. Kuku, do you have anything to add to that?
Yeah, there hasn't been a lot of models. There have been, churches have been, as Margaret has said, churches have been very key in this process about where one can have tailored messages to the community. Mosques and other social gatherings have been areas where attempts have been made to disseminate hepatitis, B and C, these types of information. So what it really requires is to have outreach efforts at multiple fronts where the population, where one can tap into the population. So that is where the type of efforts that are going on. And there have been a lot of support from national funding agencies to have religious organizations included in this type of outreach efforts. In addition to that, education, schools are also very important here. So it's important to go to the communities, where the geographic areas where African immigrants are, and try to intervene through their schools as well, their educational systems, so that right from the bat, the children are aware about these conditions. Some of them will bring it back to their homes, discuss it with their mothers, and so on and so forth. Those are some of the ways that one can increase the outreach. Language, of course, is a barrier here, and therefore having the information accessible in different languages and in an accessible format is important. I have a colleague who now all the young kids are dealing with mobile phones. So I have a colleague who is just we're working on a grant where we are trying to figure out how we can disseminate some of this information through the use of mobile phones, because all the youth in particular, they might go to first generation, second generations. Yes, the printed information is important. Having this information available on a mobile phone that they can have access to much more readily may become one of the newer ways of intervening in the population.
Okay. Well, we're a minute after 3 o'clock now, so we want to thank everybody again for participating. We really appreciate it. A lot of you are sending messages and talking about how useful this is, and hopefully we'll be able to do it again. There are a couple of requests for the slides. I'm not sure what we're going to do about that. These are new slides. Okay, I'm told it's going to go out, so you guys are going to get the slides. The question was, can it be posted on your website? That we have to find out. Yes, we will let you know that at a later time. And Dr. Kuku, thank you so much for taking the time out to do this. As you can, you're not here, but if you're here, the dashboard is lit up with people saying how much they appreciate this. So.
Thank you very much. And once I receive the questions, I'll ask them. And thanks very much for the Office of Minority Health and for all the attendees also. We really appreciate this. Thank you very much.
Okay, everybody have a good Memorial Day weekend. Bye.
Bye.